Hi everyone. Thanks so much for joining us today. Hopefully we'll get to see your lovely faces in person really soon. I know I am definitely looking forward to that myself. My name is Debbie Bryson and I serve on the Board of CAPS for many years now with great pleasure. I've joined you today to go over a couple of quick announcements before I introduce our wonderful guest speaker, which we're very excited about. So real quick, we have a really big event coming up, our virtual Fall Gala 2021. I can't believe I'm saying that. It's going to be November 4th from 7 p.m. to 8:30 p.m. We're very excited about this. Last year's was a bigger success than we thought possible, and which we really needed in the midst of all that's going on. So we know that we can, hit our marks again this year with your help. So please save the date again, November 4th, 7 p.m. to 8:30 p.m. You'll be receiving emails through Constant Contact. It will also be listed on our website. We have some save the dates going out. It's going to be a wonderful, fun event again with some live music again. We're going to have our raffle, our auction items, some fun trivia games going on between the live streaming event. So we're going to have a lot of good fun, and we hope that you log on. You can, once you receive your email, there'll be links to go on and pre-register. It is a free event. For those of you who pre-register this year, we have a great goodie bag that you're going to get. Our theme is a Texas theme this year, so we've got some wonderful things in it, and Stubbs Barbecue donation, so and lots of good prizes in there, so we're excited about that. The second thing I wanted to tell you about is kind of stemming off our Fall Gala fundraiser. It goes to sponsor a lot of the wonderful programs that CAPS does. We have our community education, which is a big thing where we reach out to facilities and hospitals and SNFs and really anybody locally to provide their caregivers, their staff, education about Parkinson's, which is so needed because not everybody in the hospital system or therapy system knows about the special needs of Parkinson's. So we do push really heavily on our education program. The other program that we need your support in is our CAPS Cares program. And that program is a free social work program that will provide short-term respite care, facility of family meetings, client and family education, consultations, which could cover recommendations for housing, any type of government assistance programs that they need to apply for, possible medication assistance, finding transportation that may be needed, any type of community referrals, helping people find housing or get into a facility or therapy or rehab or SNF, food assistance, home safety evaluations, and I think I already mentioned respite care. So we have been able to grow that program tremendously, and I'll have to brag on one of our board members, John, who landed us another grant for our CAPS Care programs, which means we can provide more of these services for those in need next year coming up. So you guys, we really need your support. We want to grow that to be able to provide as much respite and resources to all of our members and family members in the greater Austin area. So, and it takes a lot to do that. So please log on and register for the event. If you are not going to be in town, you can email it out to any of your families and friends, post it on your Facebook for us, and just help us spread the word. So I'm going to go ahead and thank you in advance for that. Okay, now I'm going to go ahead and introduce our wonderful speaker for today, Dr. Erik Krause. He is a movement disorder specialist. He graduated from Nova Southeastern University and went on to do his fellowship in movement disorders from the University of Texas Health Science Center in Houston. And more important than that, he's just a really nice guy and very, very kind. And it's always a pleasure to have him. He's going to be talking to us today about why sleep matters with Parkinson's. So, Dr. Krause, take it away.
Hi, everybody. My name's Dr. Erik Krause. I'm a neurologist here in Austin, Texas with Ascension Seton Medical Group. And I've been asked to talk about why sleep matters in Parkinson's disease. This is hosted by the Capital Area Parkinson's Society. Again, I'm a movement disorder specialist, which means we treat conditions such as Parkinson's, which is one of the biggest things we see in our clinic. So this is something that's near and dear to my heart, and hopefully you guys enjoy and get something out of this. So at first, I have no relevant financial disclosures. I work with CAPS. However, I receive no financial gifts from them. Okay, so what are we going to talk about today? We have a wide range of topics. Obviously, the background of sleep is a lecture in itself, but we'll try to get through that with some ease. Then we'll talk about the disability and burden of Parkinson's disease on sleep. And then why are we having our sleep interrupted in Parkinson's? There's several reasons we'll talk about. And how can we manage this with lifestyle and medications? And then what's down the pipeline? Is there anything that we can do in current day? So Parkinson's disease, just a little background. As you can see, this is a nice graph showing the burden and the prevalence of Parkinson's as we've gone through the years. It's projecting. As we get older as a society, Parkinson's disease will become more common. The biggest risk factor for developing Parkinson's is age. So it makes sense, as the longer we live, and we're getting pretty dang good at that, the more likely we're going to be able to, unfortunately, develop Parkinson's down the road. So about 1% of people in the US is over 60 years old has Parkinson's. That's about 1 million people in the US, if not more, actually. I think that number is probably outdated. Treatment is better, like I said, and we have a longer disease duration. So this is kind of unfortunately, the problem is that more people are going to get it because we're just living longer and we're able to treat it longer. So people are living with the disease for over 20 to 30 years now. Again, symptoms are treatable with medications and lifestyle changes, but we do not have a cure for Parkinson's, and that is in the process. Hopefully in the next decade or so, we will find one. And just briefly, Parkinson's disease is due to a lack of dopamine, which is a neurotransmitter that's mostly made in your brain, although it can be found throughout the body. So talking about Parkinson's disease symptoms, we can divide this. This is a nice graph or a nice figure that we like to use in the movement disorder world, where we use the glacier metaphor, where you can see the motor symptoms of Parkinson's, which everyone knows about: tremors and stiffness and gait changes. The way you walk is stooped, and smaller steps and shuffling. But underneath there, all the water is the crux of a lot of the disabilities that you see in Parkinson's, which is what we call the non-motor symptoms. And those include things like constipation, depression, anxiety, cognitive impairments, swallowing issues, and then obviously sleep, which is, quite frankly, one of the most burdensome symptoms for people. And we'll get into why that is. But again, this is just to show you that a lot of the non-motor symptoms that people, people think classically of the motor symptoms, but all these non-motor symptoms can be very burdensome to patients too. So talking about sleep symptoms in Parkinson's, this is from an article in the Movement Disorder Journal where, insomnia probably is the most common. With about 46% of Parkinson's patients in this study reported insomnia, which is almost half. That's a lot. And then another very common thing you can see in Parkinsonian syndromes is acting out dreams, which is also called REM sleep behavioral disorder. And we'll talk about that a little more. And then restless leg syndrome, also about 1/3 of patients, has this as well. And that has to do with this correlation with dopamine. We'll get into that too. Vivid dreams, which goes into the acting out dreams, is very common, and daytime sleepiness, which again kind of runs into some of these as well. So, we've done surveys and showing how much this can cause problems in Parkinson's. And there was one in 1988 actually that showed among Parkinson's patients, 98% of people had disabilities at night or upon waking. So that's essentially everyone. And whether or not that's insomnia, whether or not it's pain, whether or not it's having their tremor come back when they awaken, essentially centering around sleep shows you that this could be a big problem in patients. What's interesting is that a lot of motor symptoms can go away, meaning your tremor when you sleep should completely go away, which you would think sleep would be the best time for Parkinson's patients. However, the opposite side of the tremor is the stiffness and slowness, which can be um, burdensome to patients during sleep as well. But that includes being stiff at night and causing pain. Sometimes people have actually curling of the toes or really painful cramping in the foot. And then also just getting even out of bed just to urinate can be really tough, especially when patients are taking daytime medicines for Parkinson's. And those may not be working at night when you need to get up out of bed or turn in bed for that matter. So again, interesting, the tremor would go away completely. However, when you get up in the morning, also, a lot of these symptoms can just kind of go away magically. It's some phenomenon we see in Parkinson's, and we just don't know really why this happens, although it probably has to do with just waking up the brain. And, for that brief couple minutes, some Parkinson's patients actually say that's the best time of their entire day is right when they wake up. In fact, that's probably the time that they don't have medicines on, ironically enough. So there is some sort of oxymoron there, but it's just something that some people report. And so, yeah, when you don't get good sleep, this can exacerbate that bottom half of the glacier, which is the non-motor symptoms, and that can cause worsening anxiety, depression, cognition and memory loss, and then just cloudy thinking during the day. So this is just this endless cycle of not getting sleep can worsen daytime things like that. So this is a slide saying, the brain and the neurotransmitters, the chemicals, the electricity of the brain, all this stuff is kind of like a homeostasis that we just is a fine balance. And in Parkinson's in particular, dopamine plays the primary role in disability. However, there are several neurotransmitters that are also affected in Parkinson's, and not only insomnia, but also other sleep conditions. These neurotransmitters are heavily involved. And so, I mean, obviously we can't go into this. This is kind of like a scientific research-based talk if we went into the details of that. But this slide basically highlights the fact that dopamine is the name of the game in Parkinson's. However, you have several other neurotransmitters that also play a role in how we sleep, and also several different locations in the brain and the brain stems. So it's this fine balance of things. And that's why, working on depression, which is a serotonin issue, hypothetically, it also involves other things, but is important to getting good sleep. Exercising and releasing dopamine and acetylcholine can help with sleep. So, again, this is just this fine balance that we have to play with. The purpose of sleep is, boy, man, that's a great slide. It's because it's just really, you could say so many things, but the basis is to recharge and to let the brain rest and form memories and actually help with cognition. So you need that rest. In fact, we'll talk about this, but you need at least 7 to 9 hours of sleep. And that's been shown by the Sleep Society of America and the Sleep Foundation. Also, people who don't sleep as well are more likely to get infections or upper respiratory illnesses. So then that's been shown. So it's also good to stave off disease, let alone help with preventing, the onset of Alzheimer's. So. And briefly, we'll go through this. I mean, again, this could be a whole talk in itself, but the stages of sleep are divided into 4. We used to call them non-REM and REM, but now we're trying to make this stage 1 through 3 and then REM. Stage 1 sleep is very brief. It's about 10 minutes, or if even that, maybe a couple minutes, but this is the light sleep where you're just kind of in and out. The body starts to relax, your heart rate goes down, you just kind of are there and easily awakened if you need to. Stage 2 is when we're getting deeper and the eye movements start to stop. They stop moving. The body temperature decreases, and this is your longest stage of sleep. Stage 3, which is the lowest level of breathing and heart rate is completely relaxed. This is the most relaxed stage of sleep. And then the 4th stage is REM sleep. And this is probably something everyone's heard of, but this is your dream state. Usually lasts usually about 90 minutes after falling asleep. And sometimes doesn't even last too long, but comes in waves, it'll come in and out. Essentially what happens is you're basically paralyzed during this, and our body does this as a natural mechanism. So we're not acting out our dreams and falling out of bed. And this will come in hand. This will be a very important thing to remember, because we'll come back to this in Parkinson's disease. So this is a slide showing how sleepy are we and how much sleep do we need. And essentially, as we get older, we basically need less and less sleep, but still the point remains we need at least 7 hours. And here's where you show that, the newborn's getting 14 hours of sleep, sleeping all day, and then long naps. So again, how does sleep apply to Parkinson's? And we'll talk about this, but we'll start with medications, some of the Parkinson's medicines and how they affect our sleep. REM sleep behavioral disorder, we touched on REM sleep, but how is this interrupted or changing in Parkinson's disease? Insomnia, is it fragmented insomnia? Is it trouble falling asleep? Do you have interruptions during sleep? Do you wake up at 2 a.m. and can't just go back to sleep? And then there's nocturia, or increased urination at night, which is probably one of the most bothersome symptoms of Parkinson's disease, is just this urge to urinate at night, or just having to urinate at night. And then restless leg syndrome we'll talk about as well. And these are all things that are associated with Parkinson's disease, obviously. So medications, and this is a tricky topic because we have medications in the Parkinson's world that can activate you, making you more alert during the day. And then we have medications that can actually make you more sleepy during the day. Now, the sleepiness medications, this is not professional advice because everyone's different. If you're taking some of these medicines, please do not worry about these. But if they're given to you, they're given to you for a reason. So please do not apply this to your situation. In particular, sleep attacks is something that we can see with some of the Parkinson's medicines. In particular, some people will be talking and then all of a sudden just kind of fall asleep. This can be very dangerous, obviously, when you're driving. So you need to be counseled on whether or not this is from your medicines and whether or not you need to stop driving. I put this in here because a lot of people don't realize this, and I think that's both on the patient and physician side, but typically we try to prescribe antidepressants for the morning. Some neurologists or some psychiatrists or some sleep doctors will actually prescribe it in the evening, ironically, because some people respond to it better that way. But for the most part, we're always taught to give it in the morning because it motivates you and gets you more activated. But there are some antidepressants which are used for sleep, and those include trazodone or mirtazapine, for example. Impulse control disorders, which are basically people who have too much dopamine from medicines and basically get addicted to things, because dopamine is one of these reward pathways. If you do get that side effect, which is very, very rare, but it can happen, this can interfere with sleep because you're too busy playing on your tablet, playing games, because you're addicted to something, So if you do feel like you're addicted on a medicine, then maybe talk to your doctor about some of this. Older age, you might be more at risk for side effects with medicines in general. So if you're on narcotics or muscle relaxants or sleeping pills, for instance, they could keep you maybe too sleepy. And then some of them might even activate you too much. So rasagiline is one of these medicines that's actually very good for, we use for Parkinson's. It's a very mild medicine. It can sometimes actually give you a little more of a boost during the day and can activate you. So moving on, REM sleep behavioral disorder. This is also called RBD. We'll reference it that way throughout the talk today. But this is a very particular syndrome where basically people act out their dreams. And that's how I ask my patients, hey, do you ever feel like you act out your dreams? Has your wife ever talked about you actually kicking or punching her on accident, or yelling in your sleep, or fighting someone? It's usually kind of a violent thing, actually. So it's odd that it always ends up being that way. And so, yeah, the patient will sometimes say no, because obviously they're asleep. They don't know if they're acting them out. Sometimes if they don't have a bed partner, they don't know that. But so then I'll ask, well, do you have really vivid dreams? And that's when they'll say yes. I have this one dream where I always am running from a person who's trying to rob me. Something very particular. And if they do actually give the history of, I do act out my dreams, I've fallen out of bed a couple times, and the spouse is sitting behind them saying, yep, I've been punched once or twice. That's one of these things that's very particular for Parkinson's and Parkinsonian syndromes, actually. And some people have shown that if you do have REM sleep behavioral disorder, up to 90% of these people end up developing Parkinson's. So up to, some studies show 60 to 90. So it's not necessarily a slam dunk, but pretty high likelihood. So if you notice that some people are acting out dreams and they're only 55 and don't have any signs of Parkinson's, that's still a red flag, and they should still be on the lookout for developing symptoms. REM sleep behavioral disorder can be seen in people who are exposed to certain medicines. So please don't confuse this with please make sure you don't think that this is just automatically Parkinson's. You need to see a neurologist before you talk about that. Don't confuse this with sleepwalking. Sleepwalking is totally different. That's a parasomnia. That means that you're getting up earlier in the night and getting up and walking and doing things. You're like getting up out of bed. REM sleep behavioral disorder is during REM sleep, and it's usually you should be paralyzed and your eye movements are going. And this can be confirmed by a sleep study. So if we need to do that, we can, but it's not necessarily necessary if you already have Parkinson's and you're getting these things. So another thing this can be is PTSD. People have really vivid nightmares with PTSD, so you have to just separate these things. And then hallucinations, which obviously you have to be awake to have a hallucination. These things can be so real that patients actually mistaken them for hallucinations. But then you ask the partner or the patient and say, well, are you asleep? And they'll say, yep. And so you say, that's not a hallucination, you're asleep. So this is a little complicated, but just to show you an example, during REM sleep, these are different sleep readings. This is from a sleep study. So what they do is put electrodes on your scalp, and they also put monitors on your muscles. And so you can see here where it says chin, leg, and arm. These are the muscles being activated during what should be a flat line of paralyzed REM sleep. So just, again, this is kind of the sleep study proof that you're having REM sleep behavioral disorder. I'm going to show you a video. Hopefully this works. This is a patient in China which has REM sleep behavioral disorder. You can see it's really violent, and that's why talking about management is important, because not only the patient can hurt themselves, but also the sleep partner can get very severely hurt. So talking about management, the first and foremost thing is actually behavioral management. So that includes keeping the bed clear of any kind of lamp that can fall on them if they're slinging their arm, or if there's anything sharp like a post or anything that they can damage their arm or hurt their head on or something like that. So you just make sure that everything's safe around them. I've actually had patients put down pillows on the side of the bed just in case they fall off the bed, and at least they'll land on some pillows. Sometimes even talking to the sleeper can help them. So if the wife or the husband is there, you can actually talk to them, and sometimes it calms them down in the middle of their sleep, just hearing a familiar voice. That brain, it just is an interesting thing how that works. But I've actually had people put on recordings when it happens, so they just press the button instead of having to talk to them. But and then, honestly, this is something you shouldn't be. This is a sensitive topic, but if you have to sleep in a separate bed until this gets resolved, then you have to. You don't want to risk an injury to not only yourself but another person. So really consider that. There are medications for this if we need to, and probably the most widely used and safest is the over-the-counter melatonin, which you can get nearly anywhere as far as like CVS, Walgreens, Amazon, whatever, but you can just use a low dose to start and then go up as needed. You can usually go up to about 15 milligrams. It's a little different here in the States versus like Europe, where they have dosing changes. And again, some of these vitamins and melatonin and things like this are not really well regulated. So in my opinion, you would probably just want to buy it from a reputable source and try not to do anything fancy like liquid melatonin or gummies. I would probably just stick with tablets. If we need to, we can prescribe a medicine, although we try to hold off on this if possible to see if melatonin works. But if they are a danger to themselves or others, then we need to start a medicine, and that would usually consist of clonazepam. Certain things can worsen RBD, and that includes certain medications. So if you are on antidepressants, certain ones can worsen it. So please speak to your doctor about that. This is not something you should discontinue. If you are on an antidepressant and you have REM sleep behavior disorder, please do not discontinue that medicine. This is something that can rarely worsen RBD. So please just talk to your neurologist. Okay, and if somebody's watching this and you have, this idea of popping in your head of, man, I think I act out my dreams, and now you're kind of freaking out of that you might have Parkinson's, please don't. Please speak to a doctor first, because this could again be nightmares from PTSD or something else. It could be provoked. So please don't freak out if you think that you are acting out dreams and you're going to develop Parkinson's. But if you do have isolated REM sleep behavioral disorder, I would really recommend considering even thinking about clinical trials, because you are one of these rare people that we've identified that you are at risk for Parkinson's. And so you might not have any signs of Parkinson's disease with tremors or stiffness or whatever. And so you would be a perfect person for someone to monitor over time to see how this, if we can predict Parkinson's better, basically. So really consider clinical trials if you do have this isolated REM sleep behavioral disorder, and absolutely establish care with a neurologist so and they can monitor you over time. And then consider a sleep study, obviously, because if you only have RBD and no Parkinson's, make sure it's RBD, because you don't want to freak yourself out about developing Parkinson's. And that's with the sleep study. Okay, moving on. Insomnia is, again, one of the most common things in Parkinson's. And we define this, the Sleep Foundation, that sleepfoundation.org is a great website. I highly recommend it. And they define insomnia as a persistent difficulty with sleep initiation, duration, consolidation, or quality. So kind of a mixed bag of everything, really. It's just an interruption in your sleep. Usually, at least for chronic insomnia, it has to be at least 3 times per week that you have this, and for over 3 months in duration. There's you can divide it into sleep onset insomnia, which is the most common, but you can also have sleep maintenance insomnia, which is interrupted by things like urinating, restless legs, or pain, or something that interrupts you during the sleep. So difficulty falling or staying asleep can be extremely burdensome to patients, especially when they have a full-time job or have to do things during the day that require a lot of attention and concentration. So that's why you have to talk to your doctor about this, because it can affect your quality of life, your job performance, and even relationships. So make sure that you talk to a doctor about this. Whenever I think of difficulty falling asleep, usually the biggest thing that I think about is difficulty turning off your mind. So whether or not it's anxiety or something stressful is going on in life, that's usually what I think is probably the biggest offender of difficulty falling asleep. Obviously, there's other things like pain or medicines or whatever, but please make sure that if it is stress and anxiety, those things are fixable, which is actually a good thing. And so we'll talk about how we can fix those. And we talked about some studies show about 60% of Parkinson's patients have insomnia, although, that other one showed 50, it's about 50 to 60. And this is more common as the disease progresses. And that's because you have more complications with Parkinson's over time. And so several things can play roles in insomnia. And this can be exacerbated by motor symptoms. So at night, if you have a really bad tremor and you're trying to fall asleep, sometimes that tremor can prevent you from falling asleep. Obviously, once you fall asleep, it goes away. But if you're concentrating on the tremor so much, it might just be so annoying to you that you can't fall asleep. Sometimes stiffness or pain from Parkinson's can occur to prevent you from falling asleep or get it comfortable. So sleep hygiene. This is probably the most important slide for everyone. So please pay attention to this. But this is how we fix insomnia. This is the lifestyle method, at least. Obviously, we have medicines if we need to, but we try to avoid those if possible. I hate just throwing medicines at people when we have fixable options here. So sleep hygiene includes having a regular bedtime routine. So, some people will go to bed at 9:30 some nights, and then, a random night they'll go to 1 a.m. to go to bed. And so that fluctuation is just not good for your body. If you can kind of expect, oh, it's 9:15 and the end of my show is done, and I know that this is my time to go to bed, then at least you've established a routine, and that can actually help with sleep. The bed is for sleep. So this is one of the most important things, especially nowadays with all these tablets and TVs and whatever else we can distract ourselves with. But the point is, when you go to bed, lights are off, you're doing nothing. We do not want stimulation for your brain, because your brain is saying, I need to go to bed. I don't need light to stimulate myself. So the bed is for sleep. Try not to play games. Try not to look at a tablet or your phone, a bright light, to keep your brain awake. Avoid late night caffeine, sugars, or alcohol. A lot of people like to snack late at night, especially with like ice cream or something. And we're all guilty of that. But if you're having sleep issues and you're doing that, then maybe cut that out. Maybe try to avoid soda later at night. And obviously, alcohol is a sedative, so it'll maybe put you to sleep, but you're not going to get good quality of sleep with alcohol. So please limit that as well. Tobacco can prevent falling asleep as well. So try to avoid chewing or smoking tobacco. Make sure you have a comfortable sleeping environment. You want to go to your bed. You don't want to dread going to a bad bed or a bad pillow or whatever, or your sheets aren't clean. Make sure that sleeping area is nice and comfy for you, because you're going to spend 7 to 9 hours of your day in that spot. So again, avoid tablet or iPhone in bed. Exercise during the day. This is one of the things that has been shown to help insomnia the most. So please exercise, and especially more so in the morning or during the middle of the day. Obviously, if you're exercising at night and that's the only way you can get it in, then by all means, keep exercising. But if you exercise, just keep in mind, you might have that adrenaline pumping and you might have more difficulty sleeping at night. Try to avoid late afternoon naps. I know being retired, you're kind of subject to naps. And so if you do take naps, just don't take them like at 4 or 5 p.m. or something. Maybe try to take it a midday nap, if anything, and try to keep it smaller. Try not to make it a big, long nap. And then there's also light therapy or relaxation techniques, which we'll talk about. Nighttime urination. This is, again, some studies have shown that this is actually the most bothersome symptom of Parkinson's. And I can attest that with my patients. It's just one of the things that people complain about the most. And it's one of the things that we have trouble controlling, quite honestly. So a couple things to think about. Avoid drinking fluids later in the evening. So make a cutoff time. So if you're getting up to urinate 5 times in the middle of the night, then hey, maybe you should stop drinking your water at like 6 p.m. instead of loading up right before bed. For the gentleman in the crowd, it's important to rule out any kind of prostate issues or benign prostatic hyperplasia or hypertrophy. If you have BPH or prostate issues, that can cause you to urinate more at night. You might need to be treated for that, which can help significantly. So that would be a good thing, actually, if you can identify the problem and treat it. If you're on a diuretic, which a lot of people are on, this is a water pill, makes you urinate more. Consider reducing if needed. Obviously, speak to your doctor about that before making any changes, but that might be making you urinate more at night. So see if that can be changed or reduced or whatever. In the middle of the night, getting up to urinate 5 times with Parkinson's can be quite the job, especially if you have advanced Parkinson's. So getting up out of bed, trying to walk to the toilet and then walk back all in the dark is probably not a great idea. So one thing to consider is to put lights around where you're walking so you know where you're going. Another thing to consider is that if you feel like your gait is very bad at night compared to the day, use a cane or use a walker there, because there's no shame in using that in the middle of the night if you need to, just to avoid a fall. During the day, if you don't even use a cane, then just consider it at night if you need to. And then people who are more advanced, consider a bedside commode. I know that sounds kind of nasty and silly, but if you can't get up to walk to the bathroom safely, then that's something to really consider, especially later on in the disease. So moving on, restless legs. This is hopefully no one here has this, because it can be really annoying to people. Restless legs is defined as having these criteria, where it's an urge to move your legs, and it's usually accompanied by some uncomfortable feeling, whether it's pain and numbness or tingling or creepy crawlies in their legs. It's got this urge to move, and you just have to do it. It's worsened with inactivity or laying in bed or being seated, usually worse in the evening, and then it's relieved by getting up and walking or moving the legs around. And the reason I bring up restless legs is that it's very common in Parkinson's disease. We showed in an earlier slide that maybe it's about 30 to 50% associated with Parkinson's. And it kind of makes sense, because restless legs has something to do with the dopamine instability in the brain. And guess what? So does Parkinson's. So on that note, you would think that treating the same thing would help, and it does. One thing you have to rule out is other things that can mimic or worsen restless legs, and that includes low back pain, neuropathy, low iron. Pregnancy can worsen, kidney disease, things like this, which if you need to treat those as well, then treat those as well, so you can help with the symptoms. Periodic limb movement of sleep is associated with restless legs, and a lot of people confuse this with acting out dreams, ironically, but it really shouldn't be. Periodic limb movement of sleep is where you just have a ballistic or a kind of a bigger movement, large amplitude movement of an extremity, and it's just kind of an isolated movement, and then it goes away. But you might do it frequently. You're not acting out dreams, but those come together, restless legs and periodic limb movement of sleep. Essentially, you don't need to know this. It's restless legs until proven otherwise. How do we treat restless legs? Obviously there's medicines for this, and usually that's the first line of how we go about this. And ironically, Parkinson's medicines can help with this. So in particular, ropinirole and pramipexole are two of the medicines that we like to use for this, and not levodopa. We try not to treat it with levodopa, so please don't do that if you can. The key is to time the medicines to when your restless legs are coming on, usually in the evening, obviously. The first line therapy is actually something called gabapentin, which you probably have heard about. This is a medicine we use for nerve pain, but it also significantly helps with restless legs. So these are options to consider and talk to your doctor about. We use, sometimes we recommend compressive devices, which have shown some benefit in clinical trials. And you can see here's a picture of one you can buy online on Amazon. And then again, we want to rule out other causes or contributors like iron deficiency or neuropathy, which is nerve damage in the legs. So if you need to talk to your neurologist about all these things, please just make sure you give them the right kind of clues to your symptoms. Sleep-related breathing disorders and Parkinson's is also common. The one thing we think about is obstructive sleep apnea. This is a very common thing in older adults, especially in America with the obesity being so common. And we've shown about 43% of prevalence of sleep apnea in Parkinson's patients, and it's usually mild, but it does show an increased incidence, essentially. That's kind of the point here. Obstructive sleep apnea is one of these things that, people have just so much difficulty tolerating a mask. Just to define obstructive sleep apnea, this is where you have a disordered breathing at night where maybe you lose your breath or gasp for air in the middle of the night, called an apneic spell. And based on how many apneic spells you have in a specific amount of time on a sleep study, that's how you get diagnosed. When you have this, it can not only lead to poor sleep quality and daytime sleepiness, but also this is a very high risk of developing cerebrovascular disease or strokes or cardiovascular disease or heart attacks. And then also is a fast track to things like dementia. So extremely important to treat. If you can't stand the mask, which is usually the biggest problem in this, is unable to wear the mask, then you need to find ways around the mask. And maybe there's the nasal route, or losing weight is the cure for sleep apnea. So if you can lose weight, sometimes people have anatomical abnormalities in their palate, which can prevent them from getting air correctly during their sleep. And then also positioning of the head when you sleep is important. Again, the treatment is to lose weight first, and then 2 is to consider the mask, which is called a continuous positive airway pressure, or CPAP. That when you get diagnosed with this, which is via a sleep study, you will need to get fitted for a mask that fits you, and do a trial with that mask just to make sure there's no air leakage or you're comfortable with it. So. And then if you have to, there are options to surgically correct, but you need to speak to your doctor to see if you are a candidate for that, or if that's something that would be even indicated. So this goes to why is sleep interrupted from Parkinson's disease itself? So meaning, the stiffness, the slowness, the tremor of Parkinson's, does that ever interrupt our sleep? And so some signs that you can look out for to see if maybe that the Parkinson's is not treated in the middle of the night, and that's what's causing you to have poor sleep, are difficulty turning in bed, difficulty getting up out of bed to urinate, or to get out and do anything for that matter. Do you wake up and have an uncontrolled tremor right when you wake up in the middle of the night? Some people, when they wake up, their mind's up and they're active, and then all of a sudden that tremor comes out and they can't go back to sleep because they're so bothered by that. Is anxiety a manifestation of not getting your medicine? Sometimes people respond to Parkinson's medicines not only with anxiety, or not only with their tremor control, but also with anxiety control. So is that a manifestation of not having enough of your Parkinson's medicines? So what I'm getting to is that if you think that the symptoms that are treated by the Parkinson's medicines come out more in the middle of the night, then maybe you need treatment for Parkinson's. And so you can consider a nighttime dose of a Parkinson's medicine, usually carbidopa, levodopa, but whatever your doctor prescribes, to see if it lasts you through the night to help you with those symptoms. And that's only if you have these types of symptoms. Otherwise, most people, well, not most, but a lot of people don't even need a Parkinson's medicine to get them through the night. So I wrote here, you can use an extended release version, and that would help us get through the night and to the morning when you wake up. And that's not an uncommon practice of ours. Pain in the middle of the night can obviously be a very big interrupter of sleep, whether or not that's joint pain, back pain, neck pain, or headaches. We need to properly identify that, because Parkinson's itself can come with pain, especially if you're stiff or rigid in one side or in your leg or your arm. It's not uncommon to have such bad stiffness in the middle of the night from Parkinson's. And so if that were to be the case, it might be worthwhile trying a Parkinson's med to help you with that stiffness at night. Again, we'll touch on the pain thing again, but this is overlooked reasons for poor sleep that I figured I would add. But back pain, difficulty getting comfortable. So maybe consider changing your mattress or stretching before bed or doing yoga or doing some core exercises to loosen up the muscles, or consider getting a new pillow. So sometimes people have neck pain, but they've had a pillow for like 10 years. So maybe it's time to change that. Are you taking a medicine that might stimulate you at night? And that includes antidepressants, amantadine, which is a medicine we use for Parkinson's, or even rasagiline, which is another medicine for Parkinson's. Those should be dosed during the morning time. So if you are on those medicines, consider talking to your doctor to see if you need those at night or not. It's very common that we just give medicines and say, hey, take this medicine twice a day. And so people think, well, I'll take it when I get up and I'll take it when I go to bed. And that's not necessarily always the case. So when you get prescribed a medicine, please clarify when you're supposed to take it, especially with Parkinson's, because the timing of medicines is extremely important. Do you have uncontrolled depression or anxiety? Like I said, this is kind of the problem with falling asleep is I can't turn my mind off. I'm thinking about things I have to do, or worrying about, my son or my daughter that's out in college, or what, out in the middle of the night. If you're always worrying about things, you can't turn your brain off. And so you have to figure out ways of working on depression, anxiety control with stress reduction techniques such as yoga, meditation. Do you practice Tai Chi? Is reading a book something that's therapeutic for you to take your mind off of things? So consider those. This is one that a lot of people have some contention about, but if you let dogs and cats on the bed, that's fine. I mean, I'm guilty of that as well. But if you have a dog that's really big and it's taking up the whole bed and you're not comfortable because of it, guess what? Kick them off the bed so you can get a better night of sleep. We don't have to medicate you with the medicine to get you better sleep. So really consider that as an option. A lot of people are just so resistant to that, which again, I'm guilty of as well. But you can't let dogs or cats take over the bed when you're suffering with sleep. A noise reduction is also important. So if you have a noisy area, like you're next to a train or airport, or people outside are loud, consider like a noise reducing agent, or putting on noise reduction headphones or music or something that can kind of blur that out. And then we talked about sleep apnea, so we don't need to do that again. A question I get a lot is, does carbidopa, levodopa, which is a very common medicine in Parkinson's disease, does that worsen my sleep or my REM sleep behavioral disorder? And the short answer is it shouldn't, no. But some people, I do have patients that come in and say, I started that medicine and then all of a sudden I can't sleep. Or I started that medicine and all of a sudden I'm acting out my dreams again. And I, personally, I think it's most likely probably coincidence. However, it has not been shown to interrupt sleep in that regard. It hypothetically could, because side effects can happen. But the short answer to this question that I get a lot is probably not. So, but always speak to your doctor about this. I mean, obviously you could have a side effect, and it's something worth talking to your doctor. Monitoring your sleep is something I recommend to people. And sometimes you don't even have to do anything. You can just wear a Fitbit or like a wearable watch or a device or something that can just monitor your sleep. Even the iPhones nowadays have apps and all these things that can monitor your sleep quality. So really consider that. So when you come to your doctor, you can say, look, I've gotten 7 hours, but I'm still sleepy, or I've gotten 9 hours, I'm still sleepy. What's going on? You can also use a sleep diary. They have apps for this. You can use just good notepad and pen. So you can always come back and talk to your doctor about it. Again, this is probably the most important way of improving sleep, in my opinion, and this goes for Parkinson's in general. Exercise is just so important. So please, please, please consider doing this if you can. It not only improves the quality of sleep, but also improves the overall amount of sleep, which is obvious. If you're tired from exercise, you're going to go to sleep. It has been proven to be effective in several studies. I mean, this is a known treatment for insomnia and sleep quality. So probably one of the most studied mechanisms of getting better sleep. And I put here, it's a catch-22. If you don't sleep, you're less likely to exercise because you're fatigued and you lack motivation. You're not going to go out and do those things. So it's kind of this endless cycle. If you don't sleep, then you're less likely to exercise, and so on and so forth. And it keeps going on. Again, we talked about when to exercise. Obviously, in the morning or during the middle of the day would be best. But if you're getting exercise at night and that's the only way you can do it, by all means, keep doing it, please. Then there's therapy for sleep. So this is actually the sleep guidelines from the American Sleep Society is actually the first line therapy for insomnia is talking to somebody. I mean, it's just as simple as that. Unfortunately, it's just not as simple as that to find a therapist these days, but we do have resources. If you think about, if you're interested, this goes back to, I can't turn my mind off. They'll teach you techniques on how to basically distract your mind and focus on getting to sleep. So it's not necessarily like I'm so depressed that I need a therapist. No, it's just talking to somebody on techniques on how to get to sleep. So consider it. The stigma of getting a therapist hopefully is not so prevalent anymore. This is something that, a lot of people need therapists, and we have, it's becoming a bigger problem every day, especially during the pandemic. So a couple resources, psychologynewstoday.com is a nice Google basically for finding a therapist, and you can use that if you need to. Headspace is a nice meditation app if you're interested. And then Talkspace is a website that you can use televisits for psychologists and therapists. Hypnotherapy has also been shown to help with insomnia. So you can consider that. And that's just recording something and playing it before you go to sleep. So then, hopefully a lot of people have heard about surgical options in Parkinson's disease, the most common being the deep brain stimulation, DBS. There are some studies that show that DBS has shown to improve daytime fatigue. Whether it's indirectly or directly, that's yet to be determined. There's also a levodopa infusion pump, which has been shown to help with daytime fatigue. Now, this is not something that I recommend getting surgery for, but if you have, for insomnia, that is, but if you have Parkinson's disease and you happen to have gotten this surgery, you could probably expect your sleep to improve indirectly as well. So again, this is not a surgery for insomnia. This is a surgery for Parkinson's, and then indirectly you might have sleep improvement as a result. I put this slide in here as a general statement, and I'm not quite sure I can name anything, but beware of sleep gimmicks. That a lot of people claim they have a cure for sleep with this one magical pill. I'd be very careful of those things. So just do your research. That's basically the point of this slide. And then a lot of people say, when do I need a sleep specialist? And a sleep specialist is a doctor that is specifically trained to treat sleep problems, including all the ones we've talked about. Obviously, neurologists, psychiatrists, general practitioners, all of us can treat these things. But if you feel like you're getting nowhere, then really consider a referral to a sleep specialist. These people, we have plenty around here in Austin, all sides of town. But usually these people are pulmonologists or internal medicine doctors, although they do have neurologists and even psychiatrists that practice this. And so a lot of people say, well, I already see a bunch of doctors. Do I really need a sleep specialist? And that's kind of a judgment call. If you have really bad insomnia or restless legs or something that's just refractive to all the things we've tried, then that's a discussion you and your doctor can have to discuss and just see if you need another sleep specialist, if you need another doctor, because, I know it gets confusing. See a cardiologist, neurologist, family doctors, and having another one in the mix. It's like, well, I'm going to start getting confused about all these people, but really consider it, because these guys are very, very good at what they do, and that's all they do. So one other word about this is neurologists, especially movement disorder specialists, we are most likely very capable of treating a lot of these sleep conditions with Parkinson's, but sometimes we aren't. Sometimes a lot of the doctors might not feel comfortable with that. If you come to me, obviously I would probably treat all these things, but if if somebody says I'm not comfortable treating this, I would recommend you see a sleep specialist, then please consider that. Nowadays, during the pandemic and even before, but a nice luxury we have now is you can do an in-home sleep study. So you don't even have to leave your house. They'll actually mail a kit. You hook it up to yourself, and then you just sleep, and it'll monitor you. And a sleep study consists of a EKG, which measures your heart rate, some electrodes for your scalp and your muscles to measure your muscle activity and your brainwave activity during sleep. Obviously, that's not the ideal situation, is to do an in-home sleep study, but it's a nice alternative if you don't want to go to a place to sleep. So consider it. And one last slide, that now that we're in this pandemic, it's almost like an obligation that we have to talk about COVID at some point. But there's this term of long haulers with COVID, people who experience complications of COVID down the road, it's months, years now down the road, when they've had a complicated case of COVID. And that would encompass sleep. And it's one of the most frequent symptoms reported 6 months after COVID infection was actually fatigue. So interrupted sleep causing fatigue, or whether it's the disease itself causing fatigue. It does seem like insomnia is actually more common in COVID survivors. It increases your risk for that. And then obviously during the pandemic, being isolated and the rate of depression is soaring, that can amplify our insomnia or interrupted sleep. So just something to think about with this pandemic. So that's everything I have. If you have questions, feel free to reach out to CAPS, and maybe I can get back to you on those. Unfortunately, this is how we do things nowadays, is with these Zoom meetings. But if you have questions and really a big, something you have to get answered, please email CAPS, and hopefully they can forward it to me and I can get back to you. But no particular medication questions, please. So I just wanted to kind of give you background on our practice. This is Ascension Medical Group. It was formerly Seton. We're moving towards this new name of Ascension, which is a nationwide group. I work in 3 different locations. One is downtown on 38th Street at the Jefferson Building. And then I also have a clinic where I go twice a week in Buda, down south. So if you live anywhere in between, feel free to make an appointment. The number here is on the left. And then I also teach over at the Dell Medical School, and I staff the resident clinic there for the uninsured. So if the neurology residency and over there is growing, and we will have 2 neurology residencies soon enough. So we teach over there as well. And I wanted to say that we do offer telemedicine visits. In fact, if you're stable and doing well and you have risks for COVID and you don't need to come in person, telemedicine is a great option. We do provide that. So please take advantage of that if you need to. And then I just wanted to thank CAPS, Capillary Parkinson's Society, for this. It was really nice to give you guys some information on this. Hopefully it wasn't too scientific, but the point is, I want everyone to know that you're not alone with these sleep issues. This is very common in Parkinson's, but we do have solutions and we do have a systematic approach. So hopefully this gives you guys a little bit of a way to look at it. So thank you very much. Very nice to talk to you guys.